Hello, my name is Tim Bateman. I'm co-director of cardiovascular radiologic imaging at the Mid-America Heart Institute and the St. Luke's Health System here in Kansas City, Missouri. I'm professor of medicine at the University of Missouri, Kansas City School of Medicine. Dr. Gary Heller, as chairman of the PET task force within the American Society of Nuclear Cardiology, has asked us to prepare a case of an abnormal myocardial perfusion PET study in a patient who has abnormal regional myocardial blood flow, so that we can discuss the meaning of this in relationship to PET versus SPECT perfusion imaging. Dr. Faraz El-Badaran is a cardiologist, a nuclear cardiologist within our program, specializing in outcomes analysis, and he has prepared this case for him. I'm going to ask Faraz to say a few words in introduction of himself.
Thank you, Dr. Bateman. My name is Faraz El-Badaran, a nuclear cardiologist and cardiovascular outcomes researcher. I had the opportunity of running into this case, which highlights some of the valuable features that myocardial blood flow analysis can add to routine analysis of myocardial perfusion imaging. This patient is a 39-year-old female who presented to the emergency department with new onset chest pain and dyspnea that started 2 or 3 days prior. At the time of her presentation, her EKG was normal without acute ischemic changes, and her cardiac biomarkers were negative. The patient was admitted for further workup. Her past history is notable for hypertension and hyperlipidemia, and she is currently on verapamil, lisinopril, and hydrochlorothiazide for control of hypertension. As an inpatient, she continued to have negative cardiac biomarkers, and a myocardial perfusion imaging was ordered for purposes of further risk stratification and for diagnostic purposes.
Now, interesting that this patient was on various medications, including verapamil, and I'm assuming that that's one reason why she was not stressed with a vasodilator agent directly from the emergency room. Do you want to comment on that?
Sure, that is correct. Typically, you would want to hold calcium channel blockers, any beta blockers, nitrates, prior to undertaking any vasodilator or exercise stress test for that matter. And that's why this patient was admitted for further workup after proper withholding of her medications.
So you went directly, or this case went directly to PET instead of some alternative type test. There may be many reasons for that. Would you like to kind of comment on some of the things that might influence in a young person like this to go directly to PET instead of, for example, a stress echocardiogram?
Absolutely. Especially being in the inpatient setting, there are probably other factors that also may influence the choice of the modality. So, for example, this patient is young. You would want to choose either a non-radiation bearing imaging modality, or if you end up choosing an imaging modality with ionizing radiation involved, you would want to choose a modality with minimal exposure to the patient. You would want to, being an inpatient, you would want a modality that will provide you with reliable answers, be able to inform subsequent management of the patient, either further invasive evaluation or discharge. And ideally, you would want to get information about longer-term prognostication and for the patient. Among the available modalities, vasodilator PET happens to fulfill most of the criteria or the conditions I mentioned earlier.
So, Faraz, you've developed a somewhat of a reputation over the last few years about analysis of radiation exposure by different techniques that we use in the hospital. Do you want to tell us a little bit about rubidium PET exposures compared to other radiation-bearing approaches that we might use in a patient like this?
If this patient is sent for a rest stress rubidium, her radiation exposure is going to be anywhere between 2 to 4 millisieverts in terms of effective dose. If she instead would be considered for a rest stress SPECT using a conventional SPECT camera with or without advanced post-processing, then we are looking at a effective dose in the range of 11 to 12 millisieverts. There's a marked difference in radiation exposure between PET or SPECT. Obviously, there are other SPECT modalities that may lower her radiation exposure, such as solid-state detector cameras, but still might not be able to bring it down to the range that we can achieve with PET.
Thank you.
So she went ahead with a vasodilator rest stress MPI with PET, and as you can see at the top is the rest images right here, and the rest images are in the bottom, and there is a large reversible perfusion defect involving the inferior wall extending from the base all the way to the apex, and it's apparent also on the gray scale and the color scale, and this area is consistent with intense ischemia inferiorly and interseptally, most likely in the right coronary artery territory. The rest of the myocardial territories appear to be preserved, no other perfusion deficits, and there's no apparent left ventricular dilatation noted with stress.
Well, what a surprise, eh? A 38-year-old lady, atypical type symptoms. I mean, somebody must have ascertained a sixth sense about this patient being at much higher risk than maybe we would have expected. And we see this severe defect infroseptally. What makes you confident that this is not an artifact of some kind?
You know, knowing that you are dealing with PET, with attenuation correction, with CT in this case, and not seeing any significant adjacent extracardiac activity, the only explanation for an inferior defect would be, in this case, ischemia in the inferior territories. Otherwise, the image quality is excellent. No other obvious sources of artifact that would affect our interpretation.
Okay, thank you. Now, so that's a very severe reversible defect. What thoughts are going through your head at this point in time?
You know, classically, when dealing with interpreting relative myocardial perfusion imaging in general, you always worry about underestimating the true extent of anatomic disease, and that what you're seeing is just the tip of the iceberg. You're only seeing the area that's most severely involved, and you might be missing other less severe or more subtle deficits. Here comes the value of PET with a multi-parametric input, where you can use different pieces of information from different domains of ventricular function and myocardial blood flow that help you form a better understanding of what could be going on.
Okay. Well, that's very good. So at the moment, what we would be assuming here is that we have a high-grade lesion, presumably in a dominant right coronary artery. But as you said, there could be much more extensive disease, or this might be all that this patient has. However, a very unexpected finding. So let's move on and look at another piece of information that will help us to better decide what is happening here.
I agree. So we're looking at the at gated function, looking at left ventricular ejection fraction, and again the stress images are shown up top, and the rest is shown in the bottom. And as you can see, left ventricular ejection fraction did improve from rest to peak stress. Calculated EF at rest was 56%, and at peak stress was 65%. However, if you look more closely, you may be able to discern certain segmental abnormalities, especially in the inferior segment where there is lack of thickening between rest and stress, and this might be indicative of severe lesion in that in that particular territory. So the fact that the ejection fraction has gone up, this has been shown in prior work to have high negative predictive value for the presence of severe angiographic disease, including left main artery vessel disease.
Okay, but the fact that there is a change in the wall motion and the wall thickening inferiorly clearly tells us that there has to be a very high grade lesion in the whatever artery is subtending that territory.
I agree.
Yeah.
I agree.
Okay, good. You know, one of the things that I'm always impressed with when I look at a gated PET study, remembering again that these are 3 millimeter thick slices, is the crispness and cleanness of the images compared to gated SPECT. Each of these slices is, and each of the frames is attenuation corrected, which is rarely done with SPECT gated images. We're usually trying to look at gated non-attenuation corrected SPECT frames to compare with the attenuation corrected SPECT images. Okay, let's look at this patient's blood flow.
So this is a snapshot of myocardial blood flow analysis that was obtained on this patient. I would like to remind you to always start in the left-hand side of the screen if you happen to have this particular program, which helps you do some quality control at the beginning to make sure you are working with high quality data and that your interpretation is reliable. For the sake of time, I'm going to move to the right-hand side of the screen, and as you can see, at rest, the myocardial blood flow readings are relatively similar. The left circumflex territory might be slightly higher, but overall, the global flow at rest is within normal limits at 0.8, which happens to be in the normal range. With stress, which is shown up here, you see that the LAD territory, the left circumflex territory, have augmented substantially, whereas the hyperemic myocardial blood flow in the RCA territory was blunted and at 1.17, and it is below that threshold that has been reported in the literature of 1.5 ml per gram per minute, indicating the presence of hemodynamically significant stenosis in that territory. Moving to the flow reserve, myocardial blood flow reserve, you see that the global myocardial flow reserve of 2.6 and a preserved reserve in the LAD and the left circumflex territories, whereas in the RCA it was also blunted. This is now the pieces of the puzzle are coming together, and we're painting a picture of most probably we're dealing with a high-grade stenosis, as you have mentioned, and it is most likely in a single epicardial territory. So here PET can give you the ability not just to direct the patients to the catheterization laboratory, but also to be able to give a highly educated guess about their potential anatomy or what they might be having.
Sure. Very good. One practical significance here, I think, has to do with patient preparation for the upcoming coronary angiogram. I think everybody would agree, just looking at the perfusion images, that this patient is destined for the cath lab. The question then comes, how should the patient be prepped for the cath lab? Often in cases like this, we would not start the patient on Brilinta or Plavix because we really don't know whether we're dealing with multi-vessel disease or not, and we don't want to get the patient locked into a long-term, week-long wait for surgery, for example, in the event of multi-vessel disease. But here we can be very confident we're dealing with just single-vessel disease. It would be very appropriate to prep this patient with Brilinta before heading off to the cath lab.
So this study was interpreted officially as a large area of intense ischemia inferiorly and infrareceptally, probably in the distribution of the right coronary artery, normal left ventricular systolic function at rest and peak stress with calculated LVAF of 56 and 65% respectively. There was blunted hyperemic blood flow and abnormal coronary flow reserve in the RCA distribution, whereas it was normal in the LAD and the circumflex territories. The patient went ahead and proceeded to the coronary angiogram, and shown are her still images of her coronary angiogram. To the left-hand side, there is a high-grade stenosis in the mid-right coronary artery, whereas on the right-hand side, you see the left system revealing angiographically normal LAD and left circumflex arteries.
All right, let's move on to your questions pertinent to this particular case.
Sure. Question number 1 is non-invasive assessment of myocardial blood flow reserve using PET MPI is associated with all of the following advantages except A, improving the ability to detect left main or multi-vessel CAD, B, enhancing risk stratification and prediction of future cardiovascular events, C, differentiating between ischemic and non-ischemic etiologies of cardiomyopathy, and D, predicting the presence of cardiac allograft vasculopathy in heart transplant patients.
Okay, so with respect to this case, if this patient's blood flow reserve had been abnormal in the LAD and left circumflex territories, much worse, obviously, in the right coronary territory because we know this patient has a coronary steal phenomenon. But nonetheless, if myocardial blood flow reserve had been reduced in those two territories, you would have assumed the likelihood of multi-vessel disease or left main disease.
That's correct.
Right.
Our confidence about her potential coronary anatomy would have been much less in that situation.
Yeah. So I think that's one very important advantage of PET. Our interventional colleagues in the old days used to complain about false positive nuclears. Now the biggest concern that they have is underestimation of disease extent, which presumably is why that knee-jerk response that any abnormality on a perfusion study gets a patient into the cath lab. So this can be very helpful in many cases in determining whether a patient really does need to be in the cath lab or could potentially be managed medically. What about B?
Enhancing risk stratification and prediction of future cardiovascular events. The prognostic value of myocardial blood flow reserve is probably the most established among the other applications of myocardial blood flow. It has been shown in multiple patient populations and patients with known or unknown coronary disease, and patients with normal or abnormal relative perfusion, and there's a wealth of data supporting its prognostic utility, and B is actually correct.
Okay. You want to talk about D?
There's also mounting evidence that PET can actually be very useful in management of patients with heart transplant patients with suspected allograft vasculopathy. And recent work has shown that there are certain findings expected or seen in this patient population, with more findings, the likelihood that they have CAV or cardiac allograft vasculopathy increases. And it is speaks to the ability of PET MPI to assess microvascular function, which is one of the main findings in CAV.
Okay, and why does it not do a good job at differentiating ischemic from non-ischemic etiologies?
Differentiating ischemic from non-ischemic cardiomyopathy might still be achieved with PET by excluding coronary artery disease, but there are no specific findings seen with PET in patients who have non-ischemic cardiomyopathy.
So that's an area, I guess, of potentially important research, because it can be in some settings an important thing to be able to differentiate whether a person's cardiomyopathy is ischemic or is non-ischemic.
So question number 2, which of the following angiography myocardial blood flow patterns accurately match? So matching angiography and MBF patterns. A focal LAD stenosis of 75% with an FFR of 0.69 and a hyperemic myocardial blood flow of 1.3 ml per gram per minute. B, a distal left main coronary artery stenosis of 90% with a global myocardial blood flow reserve of 1.3 times baseline. C, angiographically normal epicardial coronary arteries with a global MBF reserve of 1.1 baseline. So I thought that all of these combinations match accurately, and scenario A resembles to some extent the case that we just presented, where you have a hemodynamically significant stenosis in one territory where hyperemic flow fails to make to the 1.5 ml per gram per minute threshold, indicating the hemodynamic significance of that lesion as is seen with an abnormal FFR. In scenario B, the fact that there is a significant left main disease can be seen in association with markedly reduced global myocardial blood flow reserve, and 1.3 is considered abnormal. With regards to scenario C, you may be able to see abnormal global MBF reserve in the absence of epicardial coronary disease in situations where there is diffuse and severe microvascular dysfunction. That might be an indication of impaired coronary vasomotor function,
or a vasodilation stimulus that was ineffective in that particular patient. Right. I usually think when I see numbers that are that low, 1.1, I'm usually thinking that that's a likely etiology, and before making other management decisions that may place a patient at potential risk, such as proceeding directly to coronary angiography, we'll often retest the patient, perhaps off caffeine for 48 hours or with a different agent such as dobutamine. Okay, very interesting case and good discussion. Do you want to walk us through the teaching points here, please?
To summarize, diminished flow augmentation in one vascular territory, defined as a hyperemic myocardial blood flow of less than 1.5 ml per gram per minute, likely indicates the presence of a flow-limiting stenosis in that vascular territory. Intact global myocardial blood flow reserve has a high negative predictive value for finding 3-vessel or left main coronary artery disease angiographically. Assessment of myocardial blood flow pattern improves the diagnostic yield of PET MPI when combined with relative perfusion analysis and assessment of left ventricular ejection fraction reserve in response to hyperemic stress.
Great. I like your number 2, actually, because we see so many people today who have a known chronic total occlusion. So one vessel is completely occluded, and the question that is being asked of us is there a second or a third vessel that's diseased? And, of course, that is very difficult with nothing but a spatially relative myocardial perfusion image to look at, such as what we have historically been doing with SPECT. It really predominantly it comes down to what is the blood flow reserve in the remaining 2 territories that helps us to know whether there's a problem. I would also say with PET, with peak stress function, we have a much greater opportunity to recognize changes in wall thickening or wall motion in those other territories as another independent marker that significant disease is present there. The perfusion obviously is always going to look much better in territories when compared against one that's subtended by a chronically totally occluded vessel.
That's right.
And the question really comes down to can we recognize presence of disease in vessels that have better flow but still horribly abnormal flow. Well, thank you very much. That was an interesting case and an interesting discussion. Any final comments that you'd like to make for us?
I think the availability of myocardial blood flow information has changed the paradigm of the way we interpret myocardial perfusion imaging. It used to be a binary decision, normal or abnormal, and with anything that is abnormal or potentially abnormal, proceeding to the invasive catheterization laboratory. Now, with the multiparametric input from PET, we are in a better position to provide more granular interpretation, not only about the presence or absence of obstructive disease, but also about the extent of the obstructive disease, and also about the integrity of the coronary circulation from the epicardial arteries down to the microcirculation, and translate that into prognostic information that informs patient management subsequently.
Great. Thank you very much.